Okay, perfect. All right. Thank you everyone for coming in today for the neuro disorder chapter. I know it's been a while since we do a live session again, but I appreciate you guys coming here. Again, I'll post the session as soon as it is available after the tutoring on YouTube, and so you guys can always come back and watch it. For this particular chapter, it is quite a long chapter, so I'm going to post the PowerPoint as well for you guys in the Facebook group, so that you guys can have the resources to study for your class. With that being said, we're going to cover neurological disorder today. This is a long chapter, and there's a lot of memorizations that you guys need to make sure that you guys know, especially about this chapter and different neurological disorders. You guys have to be able to distinguish from the assessment data which kind of the disorder, neurological disorder that is, in order to appropriately choose in the test. And also we're going to cover how we are going to treat stroke, as well as giving tPA, which is a anticoagulant medication, and thrombolytic medication, that's what I meant. So we're going to cover that in this chapter today as well. Okay, so let's go ahead and get started. Sorry. Page. Okay, so neural alteration in sensory perception is relating to neuro as well. Sensory perception is we able to sense, we able to have sensation is because there are neural there are neural connecting to our brains that deliver the electronic responses in our brain and deliver the sensation that we feel. So there are different alteration in vision. There are three that we really have to know for this chapter. That is cataract, glaucoma, and macular degeneration. So cataract, in simple terms, they are just like a cloudy lens. Glaucoma is the increased pressure in the eye that may lead to permanent vision loss, and macular degeneration is decreased vision over time due to old age, and also the structure of the eyes. So let's first go over cataract. Cataract, the patho is basically, it's the clouding of the lens. Causing of cataract is aging, diabetes, and UV light. Overexposure to UV light, meaning consistently looking at the sun, or overexposure to human-made UV light can damaging the lens of the eye and lead to clouding of the eyes. So someone who may have cataract will have these clinical manifestation: blurred visions, increased sensitivity to glare, reduced light transmission, and sensitivity to light. So I will take away blurred vision and sensitivity to light. These are the really key manifestation of cataract, so you guys should know. How do we diagnose cataract? Visual acuity assessments, Snellen chart, slit lamp examination. Don't worry about that, she's not gonna ask you. But definitely know the clinical manifestation, because it is important to know the assessment for someone who have cataracts. Treatment: surgical removal of the lens and lens replacement. So sensitivity to light is the inability to transmit light. That is the reason why cataract, people with cataracts, they have sensitivity to light. Treatment is they done one at the time. So this is important to remember. When they do surgery for cataract on the patient eyes, they don't do both eye at the same time. They do one eye at a time. And then after that one eye is healed and able to see clearly and the cloudy lens is removed, they then move on to treat the second eye. Okay, so that is important to remember, and it may comes up on the exam. Nursing consideration for treatment, pre-op, so pre-operative, we have to dilate the eye by using eye drop, put the patient on steroid to suppress the inflammatory response, and also give them antibiotic to prophylactically prevent any infection that they may have during the surgery or after the surgery. Post-op, definitely as a nurse, you have to teach the patient to protect the eye by using eye patch or eye shield. So it's really important if there's a question, for example, what do we do post-op for a patient? What you would do is you teach the patient to use eye patch on the eye and keep the eye patch on the eye. And then when they sleep at night, they should have a face shield so that they don't touch their eyes or accidentally remove the patch. Make sure that they always wear sunglasses because again, sensitivity to light is one of the biggest assessment for cataract. So make sure that they wear sunglasses even though post-op. Post-op day 1, tell them to restrict the activity, avoid things that increase intraocular pressure. Post-op day 2, resume light activities. What are the activity that may increase intraocular pressure? For example, something that like involve like tilting the head down or tightening the shoes, those can cause increased intraocular pressure, or weightlifting, those can cause increased intraocular pressure. So we have to teach the patient to avoid that. And then we also, yeah, absolutely. So steroid and antibiotic is because we give them steroid in order to reduce the inflammatory. So the question is, can you repeat why do we need to administer steroid and antibiotics? Okay, so the reason why we give the patient steroid pre-operatively, steroid medication are like corticosteroids or anything that ends in roids, meaning steroid. These medication will help to depress the patient immune system and also depress the inflammatory process so that when they do the surgery, the body does not react too harshly to the surgery, and then the patient healing time will be faster. So that's why we give the patient steroid. So the patient will be not as swelling because of the inflammatory process was reduced by the steroid. And because we give them steroid, the immune system is suppressed. So that's why we have to give them antibiotic in order to prophylactically prevent any infection that may occur during the surgery. Because cataract is an invasive surgery. They literally cut off the lens. So there's an involvement of foreign object into the body, so therefore there might be risk of infection. So that's the reason why we have to use the eye drop to dilate the eye so that there are increased surface for the surgeon to do the operation, and then steroid to decrease the inflammatory process, and antibiotic is to kill any or prevent infection. Okay, so I hope that makes sense. So post-operatively, we have, as a nurse, we have to continuously monitor for the patient temperature. If the patient temperature is more than 100.4, that means that they are having a fever and might suspect of infection, so need to call the doctor. Purulent drainage, also an indication of infections. Bleeding is also a number one complication and call the doctor. So one of the question I remember until this day when I doing the test for this chapter in MedSearch was the patient continuously complaining about pain after the cataract procedure, and what do as a nurse you should do. So as a nurse, you definitely should contact the doctor if the patient complaining continuously about pain after this procedure, because that is not an expected side effect. Okay, so just keep in mind that. All right, let's move on to glaucoma. Glaucoma, like I said earlier, it is the increase in intraocular pressure that may lead to or progressive to permanent vision loss if there's no prompt treatment. So basically, glaucoma is the aqueous duct where the water from the eyes is drained, is clogged or damaged. So because the aqueous duct is clogged or damaged, the aqueous fluid in the eyes cannot flow, and this buildup of fluid, because it cannot be drained and increased fluid in the eyes, will lead to increased intraocular pressure. And to a certain point, when the pressure is too high, the patient will not be able to see anymore. So what are the early clinical manifestation? Early clinical manifestation include increased intraocular pressure, of course, decreased ability to focus because the patient will be having pain in the eye because of the buildup pressure, inability to regulate pressure. So late clinical manifestation, ocular pain. So when the patient feel excessive or severe or even moderate pain, that means that it's already entering the late state, and that's quite bad. Vision loss is obviously the late state and really bad, and headaches. Diagnostics test, how do we diagnostic glaucoma? We measure the intraocular pressure by using a puff of air. That is a diagnostic procedure where like the doctor like blow into the eye, and then there will be a machine where they can measure the pressure in the eyes. Yeah, I don't think you guys need to know that. Treatments include eye drop, surgery by laser, trabecoplasty. Okay, so ocular pain is because of increasing pressure in the eyes. So that makes sense, right? There's a duct in our eye that continuously draining the water, the aqueous water in our eyes. If this duct is clogged, the water is not being drained, and the water, if it's not being drained and it's still being produced, it will build up, and causes increasing pressure. So laser trabecoplasty is the procedure treatments for glaucoma. It's literally opening the hole by using the laser to burn the hole open, the aqueous duct. Normal side effect includes swelling, pain, inflammation. That's obviously whenever you guys cut the body or burn the body or anything, there will be swelling, pain, and inflammation. That is part of the body defense mechanism. Pain more than 1 day is an issue. So the pain should not be more than 1 day. Post-op. Nursing care treatment is lifelong. Eye drops forever. Need to follow the drug regimen and assess this. Okay, so we have to teach the patient that lifelong medication is required for someone with glaucoma unless they have a permanent treatment like the trabeculoplasty. So teach the patient that to follow up eye exam. That is critical, very important to teach them that, and then make sure they can see the medication bottles. All right, let's move on. Next is macular degeneration. So basically this is the deterioration of the central part of the vision loss. This is lose the central vision. Intervention, maximize independence and safety. So with any vision loss, we want to promote independence, and safety is key. Okay, let's move on. So now that we already good about the eyes, we move on to the ear. So there's different alteration in the ear that relating to the neurological disorder as well. So first is conductive hearing loss, sensorineural hearing loss, and Meniere's disease. Okay, so out of these three, I would say focus mostly on the Meniere's disease, but we have to go over all of them. Conductive hearing loss is basically the sound waves do not travel into the inner ears. So the causes is because cerumen is basically like these earwax. Long-term exposure to loud noises, meaning listening to using airport or listening to music at a really high frequency or high volume for a long period of time. Clinical manifestation is tinnitus, inability to hear in a group, turning up the volume on TV, asking to repeat the questions multiple times. Treat the underlying cause, meaning that if the patient ear is impacted with cerumen, meaning earwax, we just have to remove the earwax, or we provide them with hearing aids. So this conductive hearing loss is mostly about obstructive and damage of the inner ear. Next, we move on to sensory neural hearing loss. So this basically is sound waves that are distorted in the inner ear related to the problem with cranial nerve 8. Cranial nerve 8, I think, is the acoustic nerve, causes by aging, ototoxic drugs, and infections. Clinical manifestation is lip reading, like the patient, because they can't hear you, so they're trying to read your lips when you talk. So the patient would talk loudly. So you guys know, right? Like when we put on our AirPod, we usually talk very loud because we can't hear the volume that we're projecting. So these are the manifestation of someone who may have sensory neural hearing loss. And then not answering the question properly, like not related to the question that we asked them. So mostly the cause of this is aging. All right, so now this is the disease that you guys want to know and make sure that you guys know for the exam. So Meniere's disease. So I just remember this as mini, like small, mini ears. So small ears disease. So that's how I remember it, Meniere's disease. Because hell, I don't even know how to, pronounce that. Patho of Meniere's disease is too much production of or not enough reabsorption of the endolymphatic fluid, too much fluid. So we have fluid in the eye, we also have fluid in the inner ear as well. So when there's too much production or not enough absorption of this like endolymphatic fluid inside the ears, this will causes whirling, dizziness, and also hearing loss. So clinical manifestation of Meniere's disease, the progressive sensorineural disease, hearing loss, and vertigo. So vertigo is like dizziness, whirling. There's no cure for Meniere's disease. The key is patient safety, and we have to teach the patient to adjust diet, low sodium. Okay, so that's really important to teach the patient low sodium diet. Why? Because water follows sodium. So if the patient have a high sodium diet, they will retain water in the body and also retaining water in the ear, which worsening the disease. Okay, so low sodium diet and clinical manifestation is vertigo and hearing loss and no cure. See, and patho is too much fluid, too much endolymphatic fluid, or not enough reabsorption of this fluid. Should be easy to remember, right? Okay, next we move on to chronic neurological problems. So the first chronic neurological, so there are many chronic neurological problem that we are going to over today. And I will tell you guys that you have to prepare to know all of them. It will be asked on the exam. This is a test, the third, this, I don't know, it's the third or second test exam, but this next coming exam will be really memorization based, because you have to know a lot of pathophysiology of and the assessment finding of each of these disorder. So please study, make the board, make a big board of each and each column for each disease so that you guys can remember them with the appropriate assessment finding, okay? The first disease is the multiple sclerosis. Also, usually people call it MS. So multiple sclerosis is damage and scarring to the myelin sheath. This is an autoimmune disease. What is autoimmune? Autoimmune is the body attacking itself. So people who have multiple sclerosis, the white blood cells and their internal body is damaging the myelin sheath, which is the sheet covering the neurons. So that's why they have, and they attack brain and spinal cords. So that's why they lead to multiple sclerosis. How do we assess for this patient? This patient will have a sensation of numbness and tingling. The sensory will be changed. They'll have motor changes, memory problems, speech problems. How do we diagnose this disease? We use MRI. MRI will show plaques in the brain, or something called spinal tap, where immunoglobulins, extra protein, will be present. Why immunoglobulin will be present? So immunoglobulin is basically the antibody. Immunoglobulins are antibody, and the reason why it is present is because it is an autoimmune disease. The body mistakenly thought this myelin sheath are foreign body, so therefore it's producing excessive antibody to attack the myelin sheath. So that's why there will be a high level of immunoglobulins in the blood. Okay. Interventions, including exercise, physical therapy, medications include steroids. Steroids have a role in depressing the immune system and also the inflammatory system. Therefore, we give to this patient so that the body don't produce too much antibody to attack the myelin sheath anymore, okay? And then there'll be on immunosuppression, immunomodulators, which is basically tell the immune system to work smarter. Diet include high protein. This is because the body spends so much of the protein that they have to creating these antibody to attack its spinal cord, to attack itself. So that's why we have to supplement the body with sufficient high protein because the body used it. And then high vitamin B12. Exercise and physical therapy is because we want to keep the patient as strong as possible. Again, the steroids shut down the immune system. So this is an autoimmune disease. We want to make it not work so hard. Immunosuppression is allowing aggravation. I don't know what that means. Immunomodulator tell the immune system to work to not. Yeah, don't pay attention to that. Safety is important, mobility is important, goals is independence and rest when fatigue, control stress to reduce exacerbation. And again, and there's no cure for this disease. Avoiding, yeah, I don't know what that means either, I'm sorry. But basically immunosuppression is given to this patient is because this is an autoimmune disease. We want to suppress the immune system to not producing too much antibody so that these antibody won't be able to attack the myelin sheath. Okay. So yeah, I don't know what avoiding aggravation or avoiding means. Yeah. Okay, let's move on. So this is a little picture about the assessment finding for someone who have multiple sclerosis. So they will have tinnitus, nystagmus, diplopia, blurred visions, and urinary retentions. So blurred vision, urinary retention, and spastic bladders also are keys assessment finding for someone who have multiple sclerosis. All right, next, Parkinson disease. I think Professor Lanessa loved to ask Parkinson disease, and I think it's follow you guys until 5th semester as well. I come across this question multiple times when studying for NCLEX. Parkinson disease is, the patho is because there are the neurotransmitter, dopamine is not enough in the body. So how do we remember it? We remember it as no dope in the park. So there's not enough dopamine in the body that lead to loss of movement and balance in patient, tremors, stoop, posture, shuffling gait, mask-like expressions. So I see a lot of mask-like expression, tremors, and shuffling gait coming up when I'm studying. So I would say that it's important to know. Intervention is we give them medication, which is levodopa, small and frequent meals, constipation, increased fiber, laxative, and stool softener. So another clinical manifestation, another assessment finding that I pretty sure that a patient who have Parkinson disease have is bradykinesia, which is slow movement. So these patients who have Parkinson's disease usually move very slow. However, the first and earliest signs of someone who have Parkinson's disease is tremors, like their hand will be shaky and tremors, and then the movement will be slower. We give them the levodopa medication. Levodopa medication is the medication where it increases the level of dopamine in the patient. How do we give this medication? What do we teach in this when we give this medication? We have to teach the patient to reduce the intake of protein, okay? So please remember that. I'll repeat it one more time. Reduce the intake of protein when taking levodopa. Why? Because the absorption of protein will decrease the effectiveness of levodopa. Okay, so we have to teach the patient to reduce the protein intake when they on levodopa. So this is the Parkinson disease. The patient will have a mask-like expression. Okay, remember that. They'll have tremors, they'll have stoop procedures, and also shuffling gait and bradykinesia. See, bradykinesia is the loss of arm swing while walking and slow movement. Yeah. Okay, let's move on. Now we have something called Myasthenia gravis, so also known as or usually called MG. The patho behind MG is acetylcholine. So earlier Parkinson is dopamine, MG is acetylcholine. MG is also an autoimmune disease. So what does that mean? That means that autoimmune disease, again, is the body attacking itself. But in this case, the body attacking the acetylcholine inside the body. Assessment include progressive weakness. These patients usually feel better in the morning. How do we diagnose for this patient, for the patient who have MG? We do a test called Tansilon test. It's saying that my internet is not stable. Are you guys able to hear me clearly still? Yes or no? Yes. Okay, thank you. All right, so Tansilon test is a test that they do to diagnose Myasthenia gravis. And then these patients usually have problems with chewing and swallowing, and MG can cause respiratory compromise issue with the breathing issue. Medication, if it's autoimmune, guys, always know steroid and immunosuppression is going to be there. Okay, if any disease is autoimmune disease, rest assured that there will be steroid or immunosuppression will be there. For this particular medication, we also give them the anticholinesterase. So we also give them respiratory support, and we give them a thymectomy because the thymus help with the acetylcholine. Soft and small foods. So side effect when we do tensilon test is tachycardia and AFib, swallowing issues, aspiration. So the patient who have myasthenia gravis, because they have a compromisation in the respiratory system, this can cause issue with the swallowing. And whenever they have an issue with swallowing, which also known as dysphagia, they can have something called aspiration, where the food or water going into the trachea instead of the esophagus, which can lead to upper respiratory infection and also the occlusion of the airway. Okay, so mestinon is the medication that we give for patients who have MG as well. And these can help with the neuromuscular function and help to get acetylcholine to the person. All right, next we have ALS disease, also known as Lugonier disease. So she may use both names. So just know ALS or Lugonier disease. Patho behind this is progressive degeneration, death of motor neurons. Assessment include fatigue while walking, tongue atrophy, atrophy meaning like smaller, and then dysphagia, meaning difficulty swallowing, extremity weakness, and dysarthria. I think that's joint pain. Note nutrition via PEG tube. Patient can die as early as 2 to 6 years from diagnosis because they have a respiratory failure. A Foley catheter because they are incontinent. Because these patients who are having ALS disease, their motor neurons are degenerated or died. So when motor neurons are died, they cannot control their motor function. And what are motor function? Walking, peeing, moving hand, or even the peristalsis, which is the process of digesting food. So they lost the motor neuron, so the body won't be able to move. So and the process of breathing is contracting the diaphragm muscle. So that is also motor actions. So because the motor neuron are dying in this disease, this patient won't be able to do anything. So patient usually have a trach. They can suffocate on the trach. So we have to make sure that we always do the trach care and also suction for the patient to get all of that secretion out so that they can breathe. Maintain skin to prevent breakdown and infection. And these patients are paralyzed. So this is someone who were diagnosed with ALS. His name is Stephen Hawking. He's a really popular, I think, in here in America. So yeah, he basically lived in a wheelchair and spoke through a computerized voice system because he cannot speak because of the degeneration in the motor neuron. And also, please remember, these patients usually only live 2 to 6 years after the diagnosis. Okay. And it's progressive, it's worsened over time with no cure. Okay, now we have Alzheimer's disease. So we are very familiar with this disease. So in simple terms, Alzheimer's disease is someone who will be forgetful to the point that they don't no longer remember or recognize the normal things or someone they love. pathophysiology behind Alzheimer's is this is the most common form of dementia. It initiates chronic and progressive. The exact source of Alzheimer's is still unknown. Clinical manifestation of Alzheimer's disease is they forgetting things, obviously. They forget how to do things. So the intervention for someone who have Alzheimer's disease is to maintain the routine. So please remember that. Routine is Alzheimer's. When you guys hear about Alzheimer's, routines. When you guys see routines in the test, think of Alzheimer's, okay? Because that's the thing that we do for Alzheimer's patient. They need a schedule routines. They need to be in the routine. When they are taken out the routine, they'll be panic and they don't know what to do. So have to be a routine. This time go to eat, this time go to bed, this time go to the restroom, this time go out with friends. That they have to have a routine. And then we have pictures of the family in the patient room to help them remember, and then safety. So eventually they will lose all bladder and bowel function as well. So we have to assess for that. So these patients will eventually forget how to do things like brush their teeth, take the shower, cook, and get lost in their own neighborhood. Okay, next we have GBS disease. So GBS disease is, I called it, like Professor Lanasa taught us to remember it as ground to brain disease. Okay, so because this disease progress from the feet to the brain. So GBS is, GBS is segmental demyelination of the motor neurons, inflammatory response that usually follow a viral infection. So GBS is caused by a virus and it is reversible. Unlike ALS, there's no cure and no reversible. GBS, even though they loses they have damage to the motor neuron as well, but it is reversible. And is progressing from the feet to the brain. Clinical manifestation of GBS is loss of motor function starting from ground and ending at brain. So that's why GBS, we remember it as a ground to brain disease. Intervention, we give the medication like immunoglobulins, IV, IG, plasma, pheresis. I think that's like the exchange of the plasma in the blood. Care is based on affected area. That means that if they have a, if the paralyzation or the infection, the viral infection is progressed to the bladder, meaning that they won't be able to control their bladder because the motor neuron that was damaged, there will be incontinence. So we have to make sure we always have a Foley catheter and make sure it's clean and it's not getting infected. So that's what it means, care based on affected area. They may need a ventilator when the disease progresses to the lungs. They won't be able to breathe anymore. So we have to hook them up with a ventilator. Yeah, a ventilator is basically they intubate the patient, they put a tube into the patient, directly to the patient trachea right here, and continuously blowing air and exchanging oxygen for the patient because they won't be able to breathe. The diaphragm is not moving. Immunoglobulin telling the body these are good protein. Usually this does not work. Plasma pheresis is to get rid of the bad plasma and putting in a good plasma. So risk factor possibly autoimmune associated with immunization, frequently preceded by mild respiratory or intestinal infection. So it's usually progresses over hours to days, and so it begins in the lower extremity and ascends bilaterally, meaning that it's symmetrical. Both sides of the body will be affected. So the first sign will show is weaknesses, then ataxia, and then bilateral paresthesias progress to paralysis. All right. Now we move on to cerebrovascular accident. So far, are you guys doing okay? How are you guys feeling? Good. Okay. All right. Awesome. Okay, so we're just gonna go ahead and get moving on. Now I'm going to cover CVA. So stroke is the main topic of this chapter, to be honest. There will be a lot of question about stroke from this chapter, so make sure you guys know by the back of your hand. So stroke, also known as cerebrovascular accident or CVA. So how do we assess or know that someone may have stroke? So there's an acronym that we can remember. It is called FAST. First, we look at the face. Is the face looking uneven? Like one side is drooping and one side is normal. And then the arm, we ask the patient to raise both of their arm up. If they're able to raise one arm, but the other arm they are not able to raise evenly, then we move on to the next step. We assess their speech. Is the speech is slurred? Are they speaking? Or are we understanding what they are talking? And then lastly is time. We note the time when they show the sign and symptom or experiencing stroke, and then we call 911 immediately. So overall, what is stroke? What causes stroke? So everybody have a brain. A brain, we able to function, able to talk, see you guys, do everything is because of our brain. And how the brain function? It need require the blood, so it would need nutrition and oxygen from the blood. So the heart continuously pumping blood into the brain through like the carotid artery and all like the arteries right here in our neck, to continuously providing blood to the brain so that the brain can be function and receiving oxygen, so there's no tissue death will be occurred. So that's why the basic overall patho of stroke is the blood flow not going to the brain. So yeah, this is just what you guys should know. We need to make sure that we mark the time as soon as they exhibit symptom of stroke, because it will give us better understanding and the window to do the intervention for certain type of stroke. Because for certain type of stroke, we will give them medications, and this medication required within the certain time window that we can give it. So for example, we can't only give this medication within 3 hours when they show sign symptom of stroke. So that's why time is important when we assess for this patient. When the patient is showing sign symptom of stroke, we have to note the time. Okay, so the first kind of stroke is the mini stroke. Why do we call it mini? It's also the proper term for mini stroke is transition ischemic attacks. So this is kind of like a warning sign for the patient. This is because there are an occlusion in the artery that obstructing the blood flowing to the brain. However, the occlusion is not big enough to the point where there's no blood able to go to the brain. The occlusion is small, but it's still obstructing the blood. However, there's still blood able to go to the brain, but it's just significantly reduced. So that's why these patients show sign symptom of a mini stroke. So this is a big warning sign for the patients that they need to modify their diet. They need to take and adhere to the medication regimen so that they will not having a real stroke, a CVA. So this is a risk factor for a big stroke. The body is saying that if I don't change my lifestyle, I may have a debilitating stroke later. So clot is big enough to change perfusion. So they have a speech problem or an arm issues that will maybe resolve in 30 to 45 minutes. That's a stroke. It doesn't have to be, it doesn't have to be like the patient to the point where they're unconscious, unable to move their arm, or having a facial droop can be also sign symptom of stroke. So yeah, so again, the clot is not too big to the point where it's completely occlude the artery, but it is big enough to change the perfusion rate. So the clot moves, perfusion improves, and symptom disappears. Lifestyle changes. Nurses have to teach, nurses have to teach the patient to take anticoagulant, stop eating fatty foods. What are bad fatty food? Those saturated food, fatty food. Tell the patient to exercise, have a low sodium diet, maintain good level of blood pressure, and stop smoking. Sign and symptom of transition ischemic attacks, mini stroke, is obviously the FAST acronym: confusion, aphasia, no talking, tinnitus, blurred vision, numbness, and tingling. We need to prevent a bigger stroke from happening when the patient having a transition ischemic attack. We have to make sure we tell them to modify everything, okay? All right, now we move on to the stroke, the real deal. So there are two types of stroke, and it's incredibly important for you guys to know the difference between these two types of stroke. The first type is ischemic, and the second type is hemorrhagic. The reason why we have to be able to distinguish which type of stroke, or know exactly which type of stroke for this patient, for a patient, is, even though the sign symptom may show the same, but the cause of these type of stroke is different, and the course of treatment is different. If we use the course of treatment for someone who is ischemic, who have ischemic stroke, to someone who have hemorrhagic stroke, this will kill the patient. You kill the patient. So we have to know what type of stroke the patient have. Ischemic, in basic words, is the occlusion of the artery where blood no longer be able to perfuse the brain. So ischemic, lack of blood, lack of oxygen, lack of nutrients, lack of perfusion, ischemic. Hemorrhagic is there is a bleed in the brain that causes blood loss in the brain. And also the blood literally bleed all over the brain and causes increasing pressure in the brain and hemorrhagic blood, okay? Usually there's an aneurysm in the brain or something like that, or a blood vessel got extended too much and it popped, causes bleeding in the brain. So that is hemorrhagic. Both are considered stroke, but they are both distinctly different because the cause. So this patient will have aphasia, broca, meaning short sentences, can understand but can't speak. Wernicke is long speak but have difficulty speaking. How do we diagnostic? So when we assess the patient and they show signs and symptom of FAST, we definitely, the first thing that we have to do before any treatment is to do a CT scan of the brain. The CT scan will show us whether it is an ischemic stroke or it is an hemorrhagic stroke, and then we can move on to the treatment. And then if the CT scan, it doesn't show anything, but we still suspect that the patient have a stroke, we then move on to do a procedure called MRI. And MRI is more detailed, and it will tell us everything about the patient and the patient conditions. So acute phase interventions include, we give them oxygen, IV access, and then maintain the airway. For hemorrhagic, we do not give them anticoagulant. Why? Anticoagulant causes the blood to clot causes the blood to be thinner and take longer to form a clot. So if they're already hemorrhagic and we do that, they will keep bleeding. They will not stop. So that's why we can kill the patient by giving them anticoagulant to someone who have hemorrhagic, right? For ischemic, we give them anticoagulant, which is heparin, and also tPA. tPA is thrombolytic. What is thrombolytic means? Thrombo is the clot, and lytic meaning cut the clot. So thrombolytic, which is tPA, the medication, also known as alteplase or something. This medication will given to the ischemic stroke patient where the clot that obstructing the blood vessel, perfusing blood to the brain, that clot will be dissolved by the tPA. Okay. So again, ischemic is caused by occlusion, a blood clot or a fat clot. Hemorrhagic is caused by burst of the blood vessel inside the brain. CT scan is the first inconclusive, then MRI. tPA is the only drug that can actually dissolve clots and can only be given within 3 hours of stroke. So that's why I mentioned earlier, it is so important for us to know the time of stroke. That's why the time is important. Long-term therapy include anticoagulant for someone who have ischemic stroke, okay? Sorry, I'm feeling like I'm yelling at you guys. I'm not. Okay, so this is the blockage where an artery from perfusing blood to the brain is blocked by a clot. There's no blood coming to this area of the brain, and it causes brain death in this area. Whereas here, the blood vessel is broke, so burst, so that it's because it's bleeding around this area, and also because it is burst, so there's no blood going to that area, so it also causes brain death. But the cause of it is different, so the treatment is different. Okay, effect of stroke. So I'll tell you guys this. You guys have to know this by heart. You have to know if the patient have a stroke on the right brain and the patient have a stroke on the left brain, what are the signs and symptoms? You guys have to know because it will be on the exam, I promise. So right brain, the patient will have left hemiplegia. Left hemiplegia meaning that the half of the left body will not be able to move. They will have paralysis of the half left of the body if they have a right brain stroke. Spatial perceptual deficit, like they have like the vision of like the space around them is deficit, it's not good. It increases their risk for fall. They will have deny or usually minimize any problems, like they will be more like dangerous. They don't consider that thing dangerous. They minimize the problems. Short attention span, impaired judgment, impulsive with safety. They don't care about safety, and impaired time concept. They don't care. They don't know, or they don't acknowledge time. Someone who have a left brain will usually have a right hemiplegia, meaning that the right side of the body won't be able to move. Paralysis of the right side of the body if they have a left brain stroke. They'll have impaired speech or language aphasia, impaired ability to determine right from left. They don't know which side is right, which side is left. They will be depressed, anxious, slow, and cautious. So you guys see how it's completely different with someone who have a right brain stroke, who is really impulsive and with safety and minimizing any issues, and then unable to perform math if they have a left brain stroke. So I usually remember it's at right brain, impulsive, reckless right brain, and language left brain. So that's how I remember it. So right brain stroke will be, this patient usually really reckless. Okay, so earlier I mentioned about tPA. So why do we have to know this medication? Because this medication have a lot of consideration and contraindication before we're able to give for someone who have a ischemic stroke. So tPA, also known as alteplase, also known as thrombolytic, can only be given for someone who have a ischemic stroke with onset within 3 hours of the stroke. And then we have to measure both the deficit, speech and movement and swallowing. CT scan does not show hemorrhagic stroke or non-stroke cause of deficit. That's the only time when we'll be able to give the patient tPA if it's not a hemorrhagic stroke. And the patient must be more than 18 years old. We cannot give tPA if the platelet level is less than 100,000. They have a significantly low or significantly high blood sugar. And then surgery in last 14 days and increase PT, PTT, and INR. Okay, so now we go on to aneurysm. So basically, aneurysm is caused by hypertension, high blood pressure. The pressure of the blood is so high that sometimes it causes these little pouch coming out of the artery or the blood vessel and causes aneurysm. And if hypertension continues, these aneurysm, this little pouch can burst and causes bleeding internally. And how to prevent this? We will do something called GDC coils to keep the vessel strong, and then or we cut the aneurysm out. So, and if it happens, we need to stop the bleeding. So priorities when dealing with patient with stroke, obviously airway always number one. And then we make sure that the patient have a patent airway, they're able to breathe. And then we do CT scan to know it is ischemic or hemorrhagic. If there's nothing show, but we still suspect that the patient have a stroke, we do MRI. After that, we give the patient oxygen. We start IV access on the patient, and then we're trying to decrease the blood pressure. And then we give them tPA if it's ischemic. And then after the stroke, we make sure to initiate fall precaution because these patients are high risk for fall. Make sure that we help them with the ADLs, activity daily livings, and then we have them with speech therapy and also after stroke, they may not be able to swallow yet. So they may have they are at risk for aspiration. So we have to make sure we assess that before we give them any food as well. All right, so that is it for today, you guys. We went over it pretty quick, so that's good. Is there any questions or anything that you guys would like me to address, or you guys need any help at all? I hope it's been helpful, and yeah. You're very welcome. When you were talking about tPA medication, I suppose, you said some labs. What are they again? Yeah, absolutely. I go back to that slide. So there's some labs that we have to take a look. Is the platelet. If the platelet is less than 100,000, we cannot give the tPA. This is because patients who have the platelet less than 100,000, they are at risk for bleeding. So if we also give them tPA, they will not be able to clot, and they will just bleeding. So yeah. And then PT, PTT, INR, these are also clotting measures of the patient as well. The lab for the patients. So yeah. You're very welcome. Do you know what happens if it passes 3 hours of stroke to administer tPA, or what can we do after 3 hours? Good questions. I don't know. So within 3 hours, you give tPA, but if it over 3 hours, I think there's different measure that they do. Uh, Maybe usually after 3 hours, if the stroke is already past the point of 3 hours, they can do like procedure where they go inside and cut the clot or something like that. I'm not sure. Sorry. But yeah, well, if there's any more question that you guys would like me to answer, or if not, feel free to leave. I will post this session on YouTube, and then I will post this PowerPoint for you guys on the Facebook group so you guys can take a look at it later. Thank you so much, everyone, for coming. And yeah, you're welcome. Good luck with everything. You're welcome. Let me stop sharing. You're welcome.